a cancer lead for North and South West London, trying to improve primary care cancer outcomes, in particular early diagnosis.
Thank you. And then Keith.
Right, hello everyone, I'm Keith Grimes. I'm a GP, founder of VR Doctors, an online network of doctors, patients and developers interested in immersive technology for healthcare like VR and AR. I am the Clinical Innovation Director of Babylon Health, provider of clinical AI services and virtual consultations, and I am an expert panelist on digital health for the Topol Review of the NHS.
And Yvette.
Hi, I'm Yvette Coldicott. I was a consultant anaesthetist and chronic pain specialist at Kingston Hospital. I left full-time clinical practice a year ago, and I'm now working at Synergix Health as Chief Medical Officer.
Excellent. So I think there might have been a little bit of a problem with the recording. So just to quickly touch base. So this is the Opportunities for Doctors in Health Tech webinar. I'm Johnny Andrews, the host. We've got 3 excellent panelists and as part of the DCW online conference series. So why have you joined this webinar? So I have a little poll. So for all our participants, we have about 20 or so. I'm just going to launch a poll. So if you could kindly have a look and submit a response, please, as to why you have attended this webinar today. This will really help us kind of get an appreciation of who's obviously here live, what kind of questions we can answer, what kind of topics we can, what kind of questions I can ask, and hopefully what kind of questions we can answer. Okay, so I'll give that another 30 seconds or so. I think about half of you have voted. But I mean, some of the things and the common questions that people have asked me and said they want to just know about a little bit more about what opportunities there are currently. Health tech is developing at a rapid rate. You know, there's so many pioneering companies just popping up left, right, and centre. It's very, very hard for someone who's maybe in full-time education or training to actually sort of even keep touch about this, keep track of all the developments. So what is the thing to focus on if somebody wants to branch out in that? So that's what we might touch on. What are the necessary skills for a medical student or doctor in order to branch out? And I'm not necessarily talking about qualifications. In medicine, we obviously tend to focus a lot on our academics, but what about the other skills that we need? Do we need to be learning about coding? And what about the interface between networking with people who work in technology as well, as in non-clinical people? So I'm just going to end that poll. So if anyone else hasn't submitted a response, give you another couple of seconds. Okay, so I'm just going to share the results there. So it looks like the vast majority, 63%, are just interested in health tech in general, which is good. So we'll keep it nice and general, guys. But I think a couple are actually, there's 3 people that are looking for a job as a clinician, and there are 3 who are not looking for non-clinical roles as well. So panelists, if you have any ideas of anyone, any company, yours or otherwise, then obviously do let us know. Finally, just to let you guys know, obviously Medic Footprints, we are crowdfunding if you haven't heard, so please do support. Not going to go on too much about that. So just going to stop this share. So I think just to begin with, if we can just sort of touch base on the transition period. So if we stick to the order, so Ishani, Keith, and then Yvette. So Ishani, tell us a little bit about, obviously you trained as a GP, and then tell us how you sort of transitioned into health tech, or how you incorporated it in what you do.
Yeah, so I was a newly qualified GP. I'm technically not a first 5 anymore, which I only recently discovered. I'm now called a senior 6, which has upset me because I'm getting older. But yeah, so when I was a newly qualified GP, I recognized there were lots of gaps and inefficiencies in the system. And I wanted to learn more about practices before I decided where to, find my occupational home. And I was being spammed a lot by agencies, and there was just so much noise in the system. And I thought, well, we use technology for everything else. Why can we not build a simple connectivity platform that connects GPs to practices? So that was done with, with me putting my own money and finding other like-minded investors. And we used our small pot of funds to create the first platform. And I met Melissa Morris, who is our CEO, and she's a former management consultant. So she had the kind of change management, understanding what was going on in PCTs back then. And I had the UX experience of being a clinician on the front line. And we kind of pulled our thoughts together and then decided to do some serious fundraising and improve the sophistication of the platform, and get technologists involved to better understand and use machine learning, which is a type of AI. And then we got our first customer, our first client, which was a GP Federation in Tower Hamlets. And so we used what we thought was just going to be a simple connectivity platform to actually work at scale and support recruitment, retention, resilience, and engagement. And we've spent the last 7 years kind of expanding that, and now we're beginning to work in trusts and in integrated care organizations. So the transition for me was identifying a problem, recognizing that I was in a position to start an idea, and finding like-minded people who wanted to see this idea grow. So networking was important, and just discussing, sharing ideas with peers who had lots of experience, and those who were also new to the profession.
So it sounds like you went at it, I mean, just like most businesses begin with, identifying a problem, trying to find a solution, and technology sort of came in to sort of bridge the gap. But at what stage did you realize, gosh, I really need to utilize technology? Was that something you were passionate about when you were a trainee or a medical student, or was that something that's been born about in trying to solve this problem?
I would not say that I am a massive fan of tech. I think that it's our business as usual. We use technology for everything, and it just seemed archaic that I would be sent 40 emails and I would have to sift through them to find the job that was right for me. So yeah, it was just kind of transposing things that we take for granted and applying it. So the idea to me felt pretty simple, but actually bringing it to life was a complicated but rewarding journey.
Absolutely. And now moving on to Keith. So Keith, you're also with a background in general practice, and I think I'll let you talk about the exciting things that you're doing, because it's not just one thing, is it? You've got quite a diverse portfolio.
Yeah, sure. Well, I'll just tell you what I'm doing at the moment, and then if you want to hear any more, I'll explain how I kind of got there. So I said at the start about broadly speaking, the three things that I'm involved in. So I'm a GP, I'm an NHS GP, have been since 2000. Do very much less in the way of clinical work now that I'm nearly full-time as the Clinical Innovation Director at Babylon Health. But the easiest way to understand where I come from, and I say this anytime I give a talk, is that I'm a geek, and I'm a gamer, and I'm a GP, and I'm those things in that order, in the sense that I came to those first. So I've loved technology as long as I can remember, and always tried to bring it into what I do. So back in the early 90s, I entered medical school with the explicit aim of trying to find some way of using technology in healthcare. That was in 1990, and was constantly told that it was going to be a useful thing, but never really found out how to do it. And that's been my story within healthcare all the way along. Now, I often tell people that I would use technology even if it made my job harder. That's not helpful for other people, of course. But along the way, I've learned an awful lot about what technology does and doesn't work. And so in my role as a GP, I've always used technology that I have to hand, because everyone will have the experience of this. If you go to your employer, the NHS, and ask for assistance with technology, you'll generally get told no first, and then maybe have a longer explanation of why not afterwards. So I used the technology I had to hand. I've been coding. I did some coding of my own. I used smartphones. I built my own wiki. I did a whole bunch of different things along the way, and then picked up scraps in terms of technology in healthcare as I went along. Now, more recently, with the rise in interest in digital health or health tech, which was previously just IT in healthcare, those roles started to come up more often. I even got to the point where I was an innovation lead at my local CCGs. But the trouble was that even though the NHS wanted to innovate, and I got to the role of an innovation lead, I was given no budget. I was once again found it extremely difficult to do anything, and was left with just doing things practically on the ground. And this is where the VR thing came in, because I've been introduced to virtual reality back in the early 90s and got very interested in it, but the technology wasn't quite so good. when the technology got good again back in the sort of early 2012, 2013, I started using it again, mainly for gaming, I have to say. But then as I started to use that more, I started to realize how it might be used in healthcare. So there's quite a strong evidence base for that. Again, if I'd gone to the NHS to try and get someone to supply this, they would have been told no. In fact, they did tell me no. But I had the technology and I had access to the patients, and I was able to speak with patients and just started using virtual reality with my patients with painful conditions. That was the principal way. And was so impressed by the effect of that I formed up VR Doctors. So VR Doctors is a Facebook group that everyone is free to join. I call it VR Doctors because I like VR and I am a doctor, but it's more than virtual reality. It's AR and mixed reality, and it's got patients and developers and so on. And through that, connected to a lot of different people. Started speaking more. That's around about that time I met up with Ishani, actually, who's on the panel here, giving a talk with Lantum. So I got more and more connected in health tech, and realized that my passion in health technology really had to be served, but I was being crushed by my work as a GP in a walk-in center. And sadly, I had a period of time off with burnout last year because something had to give. I spent 5 months off. You know, I was badly damaged by this. You hear a lot about prevention of burnout. I got burnout. And I'll tell you, it's very unpleasant, and coming back is hard. But when I came back, I thought, I'm not going to subject myself to this again, and decided to pursue health tech properly. And just as it so happened, at that point, Babylon got in touch. I'd had this prolonged flirtation with Babylon and understanding their technology, and the opportunity came on board to be their innovation director and help with their clinical AI fellows. And I've been with them since earlier on this year, and I am utterly delighted with that work. So I do VR Doctors, I do that, I still see some patients, and then I connect with an amazing community of health tech entrepreneurs, people like Ishani and Yvette, and also invited to help the NHS with programs about how we teach the next generation of doctors. So hopefully that's not too long a trip, but I think summarizes everything.
Not at all. That was a really good summary, actually. I think you've actually sort of mentioned, touched on lots of concepts that I'd like to sort of maybe pick at a little bit later on. Just to all the attendees out there, just so that you know, you can get involved. There is a Q&A button that hopefully you have access to. Just type a message. All the panelists will be able to see it, including myself. So one of us will either type a response, or we can actually answer it live as well. And I'll do my best to moderate that and try and actually actively ask these questions. So please do engage, okay? Because it really does form what we actually talk about. Okay, now moving on to Yvette. So we've spoken about from two GPs, and you're an anaesthetist by background. Normally probably working with a lot of technology inherent with, ventilators and that sort of thing. But I understand that, there's quite a big difference between hospital-based clinical medicine and the technology associated with that, and actually the direction that healthcare is going in terms of technology. Tell us a little bit about your journey so far.
Yeah, sure. So, as you say, I sort of had a very clinical career and quite a sort of standard traditional training, going from medical school through medical rotation, MRCP, and into anaesthetics. And all that time was sort of feeling quite frustrated that I couldn't do what I wanted to do, which was difficult to define. Possibly one of the reasons it took me so long to get there was sort of finding it a challenge to define exactly what it was I wanted to do, but something which was much more about making improvements, sorting out operational inefficiencies, improving the way that patients had access to their care, and improving the sort of the involvement of patients in their care. So I sort of carried on through my anaesthetics training, getting more and more frustrated with that, and ultimately took a consultant job, again sort of thinking that this might be a great way where I could make a difference and start to see some improvements in hospitals and be more involved with that sort of thing. Ultimately, there just aren't enough hours in the day, and as Keith alluded to, you kind of got to pick what's right for you in your life, and the hours in the day weren't enough, especially balancing that with what's now 2 growing up children, but life's busy outside work, and work really has to fit around that for me. So I took a step back a few years ago and just sort of worked out that if there weren't enough hours in the day, was I going to carry on this treadmill that I had been on for the sake of the fact I'd invested so much into it, or was I going to get off that treadmill and go where I wanted to go And then if there was still time to see patients and be involved, then absolutely, then there was no reason not to do that. So I had no desire to leave clinical practice so much as a desire to start doing, this other thing. And it was it an itch or was it more than that? Working chronic pain was sort of a brilliant balance. And as you say, anaesthetics itself is quite technological, but my real passion for helping people to manage their own health, to be in control of their own destiny, that's where I was really able to sort of bring that into its own in my chronic pain work. So I sort of started talking to hundreds of people and looking around and trying to work out how I could continue to make that difference, but on a bigger level, and where in my clinic I could make a difference to one person at a time. And I have no doubt that was a great difference. And the approach that I had was, very much about coaching them to manage their own pain. It was one person at a time. And in terms of sort of needing a challenge, wanting to get involved with some more sort of operational improvements, some leadership, and deep down an interest in technology, gadgets, not to the extent that Keith has, and I certainly hadn't ever coded, but I'd wired some category 5 cabling around my house once when the builders were there because they couldn't be bothered to do it. And there's a lot that you can learn pretty quickly with a bit of help from the internet. So putting it all together, and I realised that actually the technology's there. Digital health is a perfect platform to enable patients to be in control of their health. That's the opportunities are there for that, and for me, it was a question of how I could put myself to best use doing it. So I started off working at Digital Health London for the Accelerator programme, which I'm sure lots of people will have heard of. It's a fantastic programme, just started its 3rd cohort of companies, very, very focused towards helping companies to have an effect within the NHS in London. That's not because London's a great place, it's purely because the EU funds it with regional money, and the regional money is given for London in this particular instance. So I worked there as an NHS navigator, which was a fantastic way of getting to know lots of different companies, lots of different people, seeing inside the NHS, seeing inside SMEs, seeing inside corporates, seeing multiple different sort of organisations, and it was a great place for me to sort of work out where I could bring my own skills and make my own difference. And around sort of same sort of time as all that was happening, Synergix approached me. Synergix owns Dr. Care Anywhere, so I'm sure more people would have heard of Dr. Care Anywhere than Synergix. Basically, it's the same thing. Synergix is the umbrella company, the owner company, and they approached me because they're expanding very fast, needing a leadership team, and looking for someone who could sort of join as Chief Medical Officer with, very much with the clinical expertise. So that's where I am now. I've been there for 6 months. Haven't given an anaesthetic for 6 months either.
Okay, I was literally going to ask. So, are you managing to incorporate any clinical practice, any of your, well, I suppose any anaesthetics?
No. So at the moment, no. It's something that's very much on my mind. The decision was to step out, do what I wanted to do, and if that included wanting to give an anaesthetic, then absolutely I would do it and I would make time for it. But the point of this was to do what I wanted to be doing with my time. The reality is I haven't had a minute to think about giving an anaesthetic. I'm maintaining a license at the moment. I need to think about how much and if I continue to do that. I'm not pushing myself. I feel, that this is now the sort of, 6 months since I gave my last anaesthetic. It's a year since I left Kingston properly. Actually, they were incredibly supportive, so we've structured it in a way that the relationship with Kingston is still very open, and I could go into Kingston any time on the bank and be working there if I wanted to. I suspect that I'm going to have to stop giving anaesthetics, I think, and the reason for that is because unfortunately it's something that's very difficult to dabble in. It's great to turn up. It's absolutely easy to go and do a session, but if you're not doing it regularly, it's not. I don't think it's safe. So I suspect I'm going to come back to where I thought I wouldn't go back to, which will be pain management. The reason I thought I would stop the pain management was because the continuity of care, obviously, in chronic pain is so important, and for your patients, you need to be available for them, especially sort of very much using a coaching and non-interventional approach to pain management. You really need to have that presence for people. But I think there are other opportunities within pain management where I might be able to become effectual and in a much less sort of present capacity, perhaps looking at complex inpatient pain, that kind of thing. We'll see what happens. Not right now.
Sure, amazing. So I mean, all three of you have really sort of forged your own careers, and I think you all sort of touched on it. The nature of medicine, or at least how medicine was it was quite slow to adopt a technology, and there was a lot of resistance at various levels. So I think you've all had to, go on your own to try and develop skills and integrate, network, and then actually ultimately find your own niche. So I think if we go back to Ishani, what advice would you give to a practicing clinician? I suppose probably a GP, because you are a GP, but any clinician at the moment who would like to get involved with health tech at some level?
So there's lots of opportunities. Obviously I'm going to talk about Medic Footprints, because I think it's a great community to hear from SMEs, which for any of you who don't know what that stands for, it's small and medium enterprises. And so companies that are looking for clinicians to help build or help co-design or kind of simply advise from a clinical perspective. Medic Footprints is a conduit for you to kind of access what people are doing in the wider space, not just nationally but globally. There's also an organization, Doctorpreneurs, where you can attend. They run conferences annually, and again, it's attended by people who are looking to innovate and talk about kind of where they're at, and they're always looking to engage and listen to clinicians. I think I always say this because I do a 21st Century GP Roadshow where I tour VTSs and do free events to talk about kind of 21st century general practice. And the one thing I always say is you must join LinkedIn. That is your digital business card. For anybody who has an interest in working in tech, health tech, the digi-health space, that is the place for people to go to find out who you are, what your interests are. And it's a great networking opportunity. And there are certain groups that you can join. So those are certainly the three things that have helped me and elevated our company. For those who already have an idea and who've already started to try and make it something tangible, the Royal College of GPs have a Bright Ideas program, and for the first time they're running a mentorship program for innovators and people who are looking for support to help resolve particular problems. I think the Royal College sees itself as not having been a major player in this space, but recognizes the importance of it, and so they're trying to offer more kind of practical and one-to-one support. So certainly keep an eye out for those. We're just about to go live with our first year, evaluate it. So if anybody is thinking about applying for next year, please start thinking about it now. And obviously, get in touch with myself. I know Keith and Yvette are always open to meeting and discussing and networking and connecting the people, people with the right people in that space. So that's what I would say. It's my tip.
Excellent. That's gold. So Keith, same question to you. But also I wanted to just touch upon, you said something quite interesting about how you, as an early adopter of VR, actually started using VR headsets with your patients. So just tell us a little bit about the practicalities surrounding that, maybe ethics and who you sought permission to do this and that sort of thing. For any pioneering doctor out there who'd like to incorporate something they're passionate about, something they already have knowledge about.
Yeah, okay. So Ishani's really covered a lot of the first things I would have said about making contact socially as well. So maybe I'll just focus about the practical aspects of this. So I gave a talk at TEDx NHS a couple of years ago, which finished with asking people to JFDI. I don't know if I'm allowed to swear or not, but the F is the sweary bit, and then the just do it were afterwards, which I got to say to Simon Stevens, which was great. Now that basically boils down into, if you're interested in health tech, you have to use health tech. Now that's not an absolute, but it certainly helps. So in my case, it was about using whatever health technology I had to hand, using it myself, using it with patients, learning from it, and then sharing it. So you can use specific health technologies here. So in the simplest sense, making full use of the clinical systems that you have, making sure that you have full use of all the technologies online to find the information for patients, maybe applications, have an understanding of what applications patients might use, and Fitbits and so on, and just explore using it with them. I mean, bear in mind that if you understand the limitations of these technologies. For example, Fitbit's a wellness device as opposed to a medical device. You may say, well, that's not clinically validated, so I won't use this. But you can engage with patients, understand what they're trying to do, and facilitate what they want to do to manage their own health. And that's the biggest thing for me. That's the most rewarding thing for me, is working with patients and not resisting them. I realized that I was saying no automatically to almost everything. A patient would say, can I email you about this? And I would say, no, because X, Y, and Z. Actually, there's nothing stopping a patient emailing me at my work address. People are very just scared about the idea. They think you might just get hammered with questions all the time. Now, what I will say is that there are ethical considerations, there are safety considerations, there are confidentiality considerations. But all of these things can be squared in discussion with a patient. So if you explain to a patient the potential risks of them using a non-secure email address to send you information, and that this may lead to the information leaking, and they have an understanding of the privacy aspects of this, they're the one taking action on this. If they have capacity to make that decision, then do it. And I learned loads and loads from this. And this is the second thing about using health tech, is that either you use health tech that's designed for use in healthcare, or you just use technology from elsewhere with your patients. Now, the examples for that would be with virtual reality. So in a little bit more detail, I had VR headsets. In fact, this VR headset just here, Samsung Gear VR, which I used with my phone. And I had this, and I was using it for gaming and just entertaining myself. Had it in the office one day, and a lady came in who'd just given birth. She was breastfeeding, and she had a large pilonidal abscess that was being dressed by the nurses, and the nurse sent her down to me because they said she was crying all the way through the procedure, and could we help her? She didn't want to take any pain relief. As you'll probably know, pain relief during wound care is a difficult thing to achieve. And ordinarily, if I'd had, what options would I have had to help this person? Essentially none, other than telling her to sort of grin and bear it, or distracting her through it. But because I had the technology, I was able to say, well, I actually have this with me today. Would you like to try it? It's not a medical device. It comes with some limitations. There is some evidence for it. It's not going to be recording any information. Would you like to try it? And she said yes, and we did it, and it worked. And it was as simple as that. And since then, I've honed what I do. I had to take that first step. That first step was taken without me speaking to indemnity first. I have to admit that. But I spoke to my indemnity shortly afterwards, and they said, this is a form of distraction. Fine, go for it. Consent them, make sure they understand what's going on, do everything you can to mitigate risks. All doctors out there will understand how to do this. You can. But take the patient with you on this one. Now, I'm not suggesting that I'm cooking up medication at home and giving them untested drugs or anything like that. There are more complex digital interventions that require much more attention, but there's low-hanging fruit as well. So if you're talking about how you make a transition into this, all the doctors and nurses and dentists and medics and vets out there watching this today will have a really good understanding of the problems their patients face. And what the solutions might be. You'll be using them every single day. Ishani mentioned this earlier on, in every other aspect I use this, and yet I have to do this the other way. Just make that jump. You can make a small jump yourself, gain experience, and then as you get more confident with this and share it, you might find one idea that you're particularly attached to with particular skills, and away you go.
Excellent. Thanks for that, Keith. That was really, really detailed. So now, same question to you, Yvette, and anyone who's just tuned in who missed the question. So the question is obviously advice for doctors, dentists, vets, anyone in practice at the moment who would like to either transition into health tech or would like to incorporate it into their ongoing practice. And I think, Yvette, if you don't mind focusing on hospital doctors, not necessarily anaesthetists, but anyone in a hospital workplace or clinical workplace, not general practice per se.
Yeah, sure. I think I'd very much echo what Ishani said about networking, and the importance of networking, especially people who are wanting to transition into sort of different types of careers, be they health tech or anything else. Networking is very easy within a health tech community because you can do it online as well as face to face. It doesn't really matter where you are in the world. And as Keith talked about his VR doctors group, which is a great place to meet people remotely. and LinkedIn is absolutely sort of a key part of that. And then I think my next piece of advice would be to spend time reading, both in what you're interested in, but also to develop what it is that you're, to develop a better understanding of what your interests are. I actually found LinkedIn was my best reading place in the early days, because I just wanted to be reading so many different newspapers, so many magazines, so many journals. And LinkedIn, if you can follow the right people or groups, it comes to you. So I think that was really important. People who are wanting to incorporate health tech into what they're doing, I think that's very different, and the opportunities are possibly more depending on what's going on where you're working, and whether you actually, if you have your own idea, people who have their own idea then can sort of try and drive that passion, especially in the hospital environment, locally, to then grow it beyond that. In my case, I didn't have an idea of anything in particular. This, it was a much more generic thing. And so in terms of incorporating, in terms of a balance, yeah, I'm going to have to think about that for a second.
That's all right. I mean, to slightly add on, touch on a Q&A that we got, someone who was coming to the end of their core medical training, and they were saying they see, the perception is that, these health tech firms are looking for the qualified GPs, the ones who are already, established and doing it. But what about, the slightly more junior doctors who are still young, still very adept with technology, still very passionate about it, can bring a lot of those skills into the workplace. But what space is there for them?
That's a great question, actually. That probably kind of helps me to come up with thoughts about incorporating that into a clinical career as well, actually. So I mean, various things. One is that digital health companies will have roles. I mean, any company that's expanding will have roles for people at all different levels. I know certainly at Synergix and Dr. Care Anywhere, we've got roles for people at all sorts of levels, both GP and hospital trainees. Actually, a few months ago, we were specifically looking for hospital trainees who'd just finished core medical, core training. That was the sort of level that we were looking for some content writing. And I'm sure many companies will have sort of similar numbers of opportunities. The other thing which I think actually is a great thing for trainees is the number of fellowships now that are coming through the NHS training programmes. So, for example, the Clinical Entrepreneur Programme, which, especially if you've got an idea to develop, then it's a very logical pathway to follow as a trainee. Even if you haven't got an idea, it doesn't stop you from applying to the Clinical Entrepreneur Programme. And I know that people are encouraged to do that. There are digital fellowships, digital pioneers, many opportunities that can be sort of DASI fellowships as well. I mean, that's more leadership, but at the same time, you can certainly have a health tech focus within a DASI fellowship. So there are lots of different ways through that where people can continue with their clinical training if that's what they're wanting to do.
Excellent. And let's just touch on another Q&A, actually. So this, I don't know if everyone is able to see it, but someone has asked about sort of new life-saving prophylaxis, so the life vest. So, I mean, we can touch a little bit. It's not necessarily, I mean, it is technology ultimately. So, medical devices as well. And I think you can probably draw on experiences as an anaesthetist with like eye gels, for example. That's something that a hospital medic or anaesthetist actually pioneered and brought into practice, and it's gone worldwide. So, I mean, what advice do you have an opinion either on the life vest itself or similar technology? And do you have any sort of advice for anyone who has similar ideas about how to sort of bring this this concept into reality?
I'm afraid I'm not familiar with the life vest, actually, and so without a chance to have a look into it, I don't really feel like I have much of an opinion on that. But I think, I mean, you're quite right. The certainly with anaesthetics, many of the devices that we use in clinical practice have been designed by anaesthetists, and very successfully, because we're using things all the time. We see what's not good about what we're using or what could be improved upon by what we're using, and if you can find someone to work with you from a sort of a production perspective or a manufacturing perspective, it can be very successful. One of the giving sets, which is used very, very commonly now was designed by one of the consultants that I worked with at Kingston, which allowed, had ports built into the giving set, so need to remove the need for three-way taps, that kind of thing. Very, very simple, but really improved patient safety. That sort of thing. The opportunities are there to do that. I think that very much comes about seeing a problem in something and wanting to improve that specific thing. It's very difficult to go out and look for something with that.
And to sort of to bring it back to primary care, and if we start with Ishani again, what obstacles have you had with either management or any obstacles that you've had with you trying to incorporate technology into clinical practice?
So our technology isn't actually clinical. It's not patient facing at all. The Lantum technology is very much kind of workforce operations side. So for any innovation or tech, or for any change, no matter how small or large, the change management side of things is often the biggest barrier to adoption. We are creatures of habit. That's just being human. And particularly in general practice, no one GP is the same, and no one system is the same, and no one practice is the same. So understanding the readiness to adopt an innovation or technology is really important. Understanding the culture of the customer is exceptionally important if you want to know where they are at. And then the levers for change. And all of these things might seem commonsensical right now, but actually in general practice training, undergraduate and postgraduate, leadership elements, change management, things that I'm uncovering in my MBA now, are so important to bringing any improvement. I would say using quality improvement methodology is a really great way to make that connection to clinicians. We love data, we love evidence, we love crunching through numbers. And I think if you're trying to embed something, the change management and the QI are often the best ways forward. I think also when you're selling peer-to-peer, it's a completely different conversation than from, a cold call from a telephone company trying to change a contract. So having reputation, integrity, and connecting the right person in your organization or the person that's kind of conjured up the thought, connecting that person with the person you're trying to market it to is really important. And I met Sam Shah, who's on their heads at NHS Digital a couple of days ago, and he actually illuminated it. He said the NHS is more than 15,000 organisations, and that's including dentistry, and the NHS employs 1.8 million people. And so imagine you're trying to market something to an audience that is so diverse and has a complete spectrum of cultures within. So you have to personalize it. You have to make those human connections in order to grow something or sell something. I don't like the idea of calling it selling something, but it's a commercial entity will call it sales. But I think you're partnering with people, and I think that's a better way to frame any new idea.
Okay, brilliant. Thank you, Ishani. Keith, so same question. We already touched on sort of obstacles you had or things you had to consider, such as like indemnity, for example, with VR in your own practice. Maybe if you're allowed to talk, what sort of obstacles do sort of bigger companies such as Babylon experience when they try and engage and provide their services?
I think the important thing, obviously there's quite a lot of public and professional interest in what Babylon and other of the more disruptive startups and scale-ups are doing, particularly in terms of providing healthcare services that are quite traditional to legacy practice. I think, without going into too much detail, because you'll understand that some of it is quite sensitive in terms of the public discussion, what I have found is that when I speak to colleagues, I go and speak at a lot of events, and I act as a sort of industry stakeholder in a lot of discussions such as the Topol review and everything. What I find when I speak to people is that, first of all, they maybe don't understand quite what Babylon is doing or other companies. They sort of see it in very, very broad strokes as to how they've had this portrayed within the media. Now, what I'm not going to say is that it's fake news or anything. I hate the phrase, But certainly, when I speak to people and I talk to them about, for example, let's talk about artificial intelligence, for example, that artificial intelligence isn't just sort of like something out of, the IT crowd, like a box with a light on top of it. It's a number of different tools that are used in different circumstances for different things, with the aim of replicating aspects of cognitive processes. Now, when you explain that to someone, and then you explain that, for example, one thing it might do is help with speech recognition, and so will allow people to communicate a little bit more easily, and then about how the data is stored and how evidence is presented to a clinician, and it's there as a kind of supportive tool to patients and doctors, then some of the challenge goes away. People don't see what Babylon's doing as principally motivated by just changing the industry for no reason, but they can see that what we're doing is we're developing tools to allow us to solve some of the problems that might be harder to solve if we approach them in the traditional way. Exactly the same with video consultations and so on and so forth. The interesting thing then comes about how you then engage with a local health service. And I am going to call the National Health Service a local health service because Babylon's mission is a global one. Every different locality across the world will have a very kind of specific issue. And how you then use those tools in different areas is the next conversation. So if I was trying to sort of summarize it all a little bit, there's actually a lot of interest in understanding what these technologies and tools might be. People are, I talk about professionals, they may be scared about the idea of change, because it is going to lead to possibly quite a different environment for them going forward. And so to what Ishani said earlier on, change management, leadership that understands what these new technologies might be and how they might be deployed, and absolutely listening to the patients. I mean, it's something that we say time and time again, but to listen to the patient means to respond to their wants as well as their needs. And I've lost count of the amount of times that I speak to colleagues in healthcare who say, we shall determine what the patient actually needs and we shall give this to them. That's a terribly patronizing and paternalistic way about things. And it is not at all surprising that patients will either take matters into their own hands and try and solve things, or that desire to try and handle their care might be serviced by other providers, Babylon being one. So I think if people start to really understand that this isn't being done purely for commercial basis, this is being done responding to genuine desires from the people that we serve, and we're developing new tools to do that. When you have this communication, then some of the tension starts to melt away a little bit. But there's no getting away from it. It's all about managing changes on a large scale. So hopefully that answers the question without it sounding like I've dodged anything.
No, not at all. I think genuine desires, and I think also probably genuine frustrations with members of the public, the end users, who are so familiar now. We live in an age where technology is so accessible. Everyone has smartphones, apps, they're very au fait with technology. So they probably do see a service that is a little bit slow, a little bit behind the trend. So,
can I just say, I mean, a really good example of that is that when I started as a GP and as a GP registrar back in 2000, to order a repeat prescription, a patient would have to hand in a piece of paper and it would take about 48 hours to make it to the pharmacy. Now in my local practice, it takes 3 days, and often I still have to hand in a piece of paper. That's nearly 20 years later. Now, I know there are ways of doing this better. Some startups are doing this. Echo is a classic example. Echo is a startup that is addressing that one specific area. It is ludicrous that 2 decades we wait for something as simple as correcting this. And I refuse to accept that healthcare is so exceptional that it cannot change this way, when we can do so much else with technology. How can it be right that there's something specific about what we do that doesn't apply to nearly every other industry? I don't believe this. It's no more safety critical than aerospace technology, which is miles ahead in this.
Thank you for that, Keith. So I now wanted to sort of move on to particular skills that you all would recommend that doctors or dentists or vets use to sell themselves if they were looking for a job, And also, if there are non-clinical attendees tuning in today as well, so any skills that they can use to sell themselves to work in health tech. And I think actually, if we start off with Yvette, we also have a question as well for someone who's an anaesthetist and is looking for how they can also explore jobs, a bit, maybe into something like teleconferencing, similar to Babylon, but within anaesthesia.
Yeah, sorry. I'm just also reading that same question. Sorry. Yeah, well, the short answer to the question, Carisha, is that yes, there are definitely opportunities for jobs at a place like Synergix, and I'm a good example of the fact that there are, because that's exactly my background and it's what I'm doing. And I think the same as we said earlier, many companies are. There are lots and lots of anaesthetists out there who are working digital health companies. You might have come across some of them already, but I'm very happy to chat about it offline otherwise, and give some examples. You were saying, Johnny, about particular skills that people need to have for working in.
Not necessarily they need to have. I mean, I think the thing with medics is we have a lot of skills already, but we're not necessarily the best at selling ourselves, of actually portraying what those skills are and how they actually relate to, say, health technology or technology at all. So the flip side is a tech company will say, well, that's all very good. You've got this, you've got MRCP, you've got PhD or whatever. You graduated top of your class. You've done audits, quips, teaching, you're a fellow, blah, 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 blah. But how does that actually relate? How is that going to help my business transform and actually be a leader in health tech?
Yeah, and that's the thing where you need to just sit back and evaluate all the things that you've had to utilise to get to that position, as you say, passing all those exams, doing all those audits, playing rugby and do whatever else you do, and you're looking at your teamwork, you're looking at your time management, you're looking at your crisis management, you're looking at your ability to do multiple things at once, you're looking at your ability to pay attention to detail, you're looking at your ability to be able to critique people, give feedback, you're looking at your ability to lead if it's a leadership role you're looking at, and different people will have different skills in that, but it's absolutely just looking at yourself from somebody else's shoes and thinking, well, that's, or looking at somebody else almost, really, and saying, well, what is it that I've done? That they are your skills. They're your very, very, very transferable skills. Medics, dentists, vets, we've all got them. And you're right, we're not very good at selling them. We don't realise we've got them. And I think that's just partly because certainly my generation of doctors went to medical school from school, and we got on this hamster wheel and we stayed on it. We never really, and I think that's changing now. I think some of the sort of more recently qualified doctors will have made a much more positive choice to go into that career and chosen throughout at different points to stay in that career. But you've got the skills, I'd say.
Would there be any specific advice you'd give to, say, either a medical student or F1, F2 or CMT who wants to dip their toe in technology? Would you advise them maybe go for an UP, which is an out of program experience with maybe a technology company, maybe doing an unpaid internship? What would you suggest? And someone in your position who's probably on the receiving end of applications as well.
I think you've got to make it work for you, and you've got to do what's right for you. For some people, that will be perhaps doing less than full-time training and having a part-time role within a company that's a provider or a technology company. For other people, it might be an UP and dedicating a certain amount of time, sort of much more full-time for it, but for a fixed period, and taking those skills then back into their clinical training. I think it's all possible. Certainly at Synergix, I've got people in my team who work 1 day a week up to full-time. And that's fine. We work with people for what works for them. It's more about having the right balanced people in the team. And the right motivations.
Is it possible to incorporate clinical work and part-time work in a company like Synergix? Yeah,
definitely. I mean, all our GPs do clinical work as well. And the only reason I've stopped giving anaesthetics is purely just working as chief medical officer, and the speed at which we're scaling, it's too full-time. But other than that, all our all our team, and actually not just the GPs, the doctors who we've got sort of in the behind the scenes work, doing a lot of the sort of the development work that we've got going on. They're all doing very part-time work for us and continuing with their clinical practice or training, whichever applies to them.
Thank you. And now if we move to Ishani, so if we focus a little bit on skills that non-medical professionals could focus on, or advice for non-medical professionals who would like to get involved in health tech. And given that Lantum does sort of HR side of things as well, you were mentioning, is there a possibility for that side of things as well?
So we regularly have internship roles, and I think some people may scoff at that because internship roles tend to not be, paid anywhere near, kind of market rates. But what we've noticed is that a lot of junior doctors and newly qualified GPs and non-clinicians are so interested in doing those roles because they recognize it will lead to something paid later on. So whether you're a clinician or not, the two things I would say is, one, you have to be very self-aware. Leadership, it's one of the core things of leadership. And often I meet people who are so green and so keen, they haven't taken the time to take a step back and really evaluate how they come across. And these are basic things that we take for granted, certainly in the clinical world, because, communication is something that we cover in year 1 of medical school. But, a basic exercise that one can do is to actually not just video yourself doing a presentation, video yourself in a group meeting, and actually look through it the way we would do it when we're kind of trying to improve our communication skills with patients, and look at your body language, look at how you communicate, look at your verbal language. And those softer skills can often make the difference. You might be competing with someone who has literally the same CV points as you, but how you come across is incredibly important, and having some humility and being self-aware are so important to leadership. The second thing is you have to have grit, and you have to hustle, and you have to be persistent. I think sometimes, particularly, Yvette, Keith and myself, we've been in these leadership and senior roles for such a long time. People can often think there's a glamour attached to it, that it looks good, it looks all glossy, but it is hard work. And we've heard stories of how people have had to have sadly or knowingly made huge sacrifices in order to progress because they have such a passion for something. So it is hard work. Be prepared. It's not going to be glamorous, and it's hard work. And if you're really committed and you're diligent and you're purposeful, and I like some Keith's written in capital letters, the hustle. It is the hustle. And there are great books out there that are recommended by Harvard Business School, by London Business School. Read, be curious, be interested, be interesting, and bring all of those elements to your face-to-face interactions, because that will help elevate you and discern someone picking you over someone else who has duplicate CV points.
Okay, thanks for Ishani. So we're just coming towards the end. I'll just a quick fire question to you. Is an MBA necessary?
No, I'm a bit of a geek in another way. So it's actually interesting. So I got offered a scholarship to attend the London Bridge division of Warwick Business School, and they have a healthcare specialism and they have a technology specialism. So for me, it was just kind of, all the stars aligned, and I was lucky to get a scholarship for this year. An MBA is not essential, but interestingly, the core modules that it covers, you can self-learn. There are many MBAs out there. You can read, you can apply it to your day-to-day. So there's leadership.
Sorry, I'm just going to stop you there just in the interest of time. But if we just go to Keith, I think there were a couple of questions live that you've probably read. If you don't mind, just a quick answer to those, please, Keith.
Yeah, sure, no problem. I mean, so I'm going to just take them in slightly reverse order, because we've got Sapphire and Dr. Addy, if that's okay. So I'll start with Dr. Addy and then move on to Sapphire. So Dr. Addy's asking about kind of being a junior doctor, how well informed you need to be to sort of understand results that are brought in by people using their own devices and so on. It's a very important point. Part of the Topol reviews, Eric Topol is a digital health clinician who's leading a review of the NHS and how these technologies are going to be used in the future, but specifically how we train clinicians to work in that future. So the interim report's already out. I'll share the link to the interim report. The full report's out at the end of this year. Basically, what we would say about that is that we need to train junior doctors, junior clinicians, clinicians in practice, senior clinicians to develop those skills. So if I was going to say the skill set that you want to do, even just working with technology, it's having a basic understanding of data science, basic understanding of technologies and how they might be regulated, safety issues as well. And then basically just having a critical eye over the information that comes in. If a person comes in with information taken off a home blood pressure monitor that's not CE marked, for example, they've used an app, you might want to look at that with a little bit more skepticism than a person who brings in one using a medical grade device. So there are ways of looking into that, but it's the basic understanding that the information that's brought into you may be questioned, but may still have relevance. So hopefully that answers a little bit about what Dr. Addy was saying. The one that I really wanted to come to was what Sapphire was saying. So Sapphire is a GP in training, if I understand this right, and has an acquired physical disability, which makes part of the practice harder. I absolutely think that the changes that are happening in healthcare, particularly digital health and health technology, will be able to support and allow you to make the absolute most of your expert skills and your knowledge and your expertise and also make use of the particular advantage you have in understanding the impact of the needs for yourself and the community of people with similar issues too. So if you have a physical disability, let's say, one of the things that Babylon's working on at the moment is how we can have natural language processing. So when you speak to a patient, the notes are automatically coded as well. And then it can then give information and decision support as well. So this is something that I'm actively working on right now. If you have that, if you have a computer that is appropriately tailored for accessibility, everything that we do in Babylon in terms of our development is to build with accessibility and equality and diversity from the ground up. So should be able to support people with a whole diverse range of potential different abilities. And if you're talking about, if you're limited in the ability to do physical examination, then something like telemedicine will suit you right down to the ground. So as I'm sure anyone here on the panel would say, always happy to be approached offline about this. I've shared my email address. I'm on Twitter if you want to just take it in more detail. And I'm particularly interested to hear about people who have less conventional approaches or minority needs in terms of the provision of medicine, because that's the secret to unlocking all this amazing potential out there that's otherwise not served in legacy practice.
Amazing, thanks, Keith. So we're into the last 2 minutes, so I think we'll no more questions for now, but the conversation can still continue. So if you'd like to ask a question you didn't have the chance to, or you'd like to ask them privately, I'm sure all three of our panelists are happy to be approached offline. You can also go to www.dcwonline.org. There's a Q&A section which you can post questions. I will moderate it. I'll keep an eye. I can also inform the panelists if they're not aware of any questions. We'll forward them on as well. Networking, we touched on networking. I think all three will agree that networking is very, very powerful, very, very important, and I'm sure they'd be happy to connect with you. And that goes for also the non-clinicians as well who are very interested in health tech. So guys, just as a quick fire thing, a thumbs up or down. Are you happy that you've gone down the health tech pathway? Any regrets? Thumbs up. Excellent, good stuff. And are you going to continue incorporating health tech in your clinical practice?
Yes, absolutely. How can you possibly doubt otherwise? Of course, I found my calling. Medicine and technology is amazing.
Okay, guys, so there we go. So that's our three fantastic panelists. Any questions, feel free to reach out to them. I hope you found it informative, and looking forward to continuing the discussion later. Thanks to the panelists, and see you guys later.
Bye-bye.
Bye.
Bye.